Hi, I'm Dr. Ted Delbridge, Executive Director of MIEMSS, the Maryland Institute for Emergency Medical Services Systems. And although I'm sure it's been overdone quite a bit in the past several months, we're going to spend a little time talking about the last year's pandemic and how EMS coped and the role that it played, a very important role, in the management of our healthcare system in response to the pandemic across the state of Maryland. And we'll touch on just some of the things that are going on that characterize the state of EMS in the state of Maryland currently. If you've been keeping score, you might see graphs like this on the internet, in the newspaper, or anywhere else where you get information. This is a display from CRISP, the Chesapeake Regional Information System for our patients. The information that it includes is all information that is supplied by MIEMSS on a daily basis in partnership with our hospitals using our statewide emergency alerting system. And you can see this as of a couple of days ago, things are looking up. The black line on the graph shows the number of patients in Maryland hospitals with COVID-19 that are in acute care beds, and the red line are the number of patients that are in intensive care units. And you can see depicted there the surge that we experienced both in the middle of the winter time and the early spring, and how the numbers of patients in hospitals have been gradually decreasing. On the right side are the numbers of patients depicted a little bit differently. The blue bar are patients in the hospitals that are unrelated to COVID-19. The narrow orange band are the number of patients with COVID-19 in hospitals. And then green band are the number of hospital beds that remain available. And there's a distinction to be made amongst hospital beds. There are those that hospitals physically have and those that they are staffed and ready to accept other patients in. And the green bar are the numbers of staff beds that are currently available. And you can see there's a little bit of a circadian rhythm. It waxes and wanes over the course of a week, depending on other business in the hospital. But hospitalizations over the past couple of months have definitely been more characterized by patients who are unrelated to COVID-19 than those with the disease. And that's all really good news for Maryland. It's interesting, here on this chart, you can see the proportion of all cases made up of different age groups. And although, for example, people greater than 80 years old represented only 4% of the cases in Maryland so far, they represented a disparate proportion of patients requiring admission to the hospital, and unfortunately, a disproportionate share of patients who died. And you can see, in general, as the population was older, there was a greater likelihood of being admitted to the hospital and or dying, which is quite unfortunate. Fortunately for younger patients in the population, the necessity to be admitted to the hospital and resulting death was much lower throughout the pandemic over the course of the past year. What is really rather interesting, though, is if you compare people who get admitted, who get COVID-19 now, as opposed to maybe people who got COVID-19 in the wintertime, the necessity for hospitalization is more than double in some age groups, meaning the current variant of COVID-19 that's circulating in the population is probably a little bit more transmissible and quite a bit more devastating in terms of the degree of illness that it causes. This is the different way of looking at the same information, the proportion of COVID-19 cases made up by various age groups. The yellow bars are for the period March 2020 to April 2021, and the red bars are for the current period April to June 2021. And as you can see, there was a bit of a shift. While earlier in the pandemic, the patients who were older comprised a majority of patients who had COVID-19. Here, most recently, the patients who are younger are the ones that are comprising a disproportionate share of illness in the community. That's likely in part somewhat due to the rate of vaccination amongst various age groups, but it's also why it's so important for people who are younger to consider vaccination. And although I showed that the likelihood of requiring hospitalization and or death amongst younger people is less than older folks, it doesn't mean that folks don't get sick. And I'm sure we know somebody who is younger who got devastatingly ill or perhaps died over the course of the past year. And it also means that people who are younger in the population are a reservoir for the virus and can transmit it unknowingly to people who they are friends with, their family, their loved ones. And so it's really important for everybody to get vaccinated. I want to talk a little bit about how we progressed through the pandemic over the course of the past year. And we're all aware of the cases that happened in the National Capital Region in March of 2020. But Maryland's first foray with COVID-19 really began on January 25th, 2020. And it was on a Southwest Airlines flight that was coming into BWI Airport from Las Vegas. And there was a passenger on the plane who had viral type symptoms. And the concern was that he may have COVID-19 as he had traveled from Asia to get to the United States. And we put into gear all the things that we had facilitated and ramped up subsequent to the Ebola virus. And that particular person went to a special pathogen receiving facility. And the first thing we learned is that we needed to dispel the notion of special pathogen receiving centers and transport unit teams. Those were concepts that were really valuable for Ebola virus, but not so very valuable for a virus like COVID-19. All the non-centers thought that they should be reserved. In other words, they didn't want COVID-19 patients in the beginning. Their posture was that we'll take care of everyone else. So we'll be the reservoir in the healthcare system to take care of all the typical things that need to be taken care of. If we had done that, the special pathogen receiving centers clearly would have been overrun, as were all the hospitals. But this was not an unfamiliar territory for us. And the coronavirus that makes up COVID-19 is not entirely dissimilar from the same virus that was responsible for the severe severe acute respiratory syndrome that outbroke in Toronto in 2003. And that virus had a case fatality rate of 9.6%. What made it a little bit different than COVID-19 was that it was very well isolated and controlled and contained. But nearly 25% of the EMS workforce needed to be quarantined over the course of the several-week outbreak in Toronto. So we were faced with a couple of questions. First one was, what do you do when you're worried about running out of people? And that was the case in Maryland's EMS system. We didn't want to run out of EMS personnel. So you have a couple of different things that you can do. First of all, you can't take care of the hurt and sick people without your very own people. You got to protect the ones you got, and you got to work on getting some more. And so we did those kinds of things. First of all, protect the ones you got. MEMS became a stockpile of personal protective equipment over the course of the several weeks and months early in the pandemic and through the summer of 2020. And we quickly learned that the National Guard took seriously a logistical mission to move around things. And the MEMS office building became a depot for PPE, often brought by tractor-trailer truckloads from the National Guard. And we spent considerable time and energy making that PPE available to the field. We provided frequent guidance to EMS clinicians. And what we learned in the early goings-on is that most exposures were unnecessary, meaning most exposures of EMS personnel to sick patients were really unnecessary exposures, often brought about because of too many personnel encountering a single case, and typically, and most often avoidable, failure to maintain appropriate precautions. And our assessment was that this was very rarely for lack of equipment or supplies. Really, it was a matter of a discipline of the EMS personnel to take advantage of the supplies that they had, which may be unfamiliar and not of the brand that they were typically accustomed to using, or maybe not of the highest quality that they were accustomed to using, but there were supplies available, and we emphasized the need to continue to use them as they should. We embarked upon a program to test EMS and firefighter personnel when there was concern, either because of symptoms or an exposure. And what we quickly learned is that the rate of PCR positivity amongst EMS and fire personnel across the state basically emulated what was going on in the general population. And you can see here through the summertime, as in the last summer, the test positivity rate decreased as it did in the general population of Maryland, and then in the fall and early winter rose dramatically. Most of these exposures and test positive situations weren't because of exposures to the public or patients. They were exposures and disease transmission that occurred at home and too often times in our fire stations where somebody would be exposed and come to work and expose an entire shift, for example. And we continue to make PCR testing available throughout the state of Maryland. Back to our people. We want to protect the ones we got. We want to get more. We were the subject of a governor executive order on March 19th that enabled us to suspend all EMS-related law and regulations for the purposes of augmenting the workforce and improving the response to the state of the emergency. And I'm going to show you some of the ways we did that. It's worth noting that our current executive order is set to expire on August 15th, 2021, so here in a couple of months. And all of the stipulations that we put into place subsequent to this executive order all have a sunset or an expire time. Some on the day of the executive order expires, some 30 to 60 days out, and in some cases we made provisions to transition to a new way of doing business. One of the things that we did was we made provisional EMS clinicians, and these were people who we could make EMTs or paramedics by virtue of reciprocity, by reinstatement of people who were expired, turning inactive people into active people, and in quite a number of cases allowing students to matriculate into the EMS workforce. There was a great deal of interest around students who had completed all their didactic training, were able to pass practical and cognitive testing, but didn't have the field experience because at the time field experiences weren't being made available to them. So we incorporated them and allowed their on-duty time to account for their needed field experience. And you can see there that we provisionally credentialed well more than 1,000, almost 1,200 people between EMTs and paramedics over the course of a year. One of the things that we've been able to do is enact a new regulation that allows these provisional people to then become full-time status folks, regularly licensed or certified people in the EMS system. And you can see there amongst EMTs, about a sixth of them have already made that transition, paramedics about the same. From the time the executive order expires in August of 2015, EMTs and paramedics have 180 days to do what it takes to move from provisional status to full-time status, and they can continue to practice as provisional folks in the interim. But at the end of 180 days, if they haven't made the move from being provisional to full-time status, they essentially expire and go off the enrollment of available EMTs and paramedics in the field. We did something very unique in Maryland. We used the MEMS licensing apparatus to credential clinical externs who were nursing and respiratory care students across the state. And we worked with all of the schools of nursing and all of the schools of respiratory care to come up with qualification levels that could be identified as being commensurate with something that the healthcare system would know. So for example, a clinical extern, Nurse 1, is essentially akin to a certified nursing assistant. And a Nurse 2 is akin to a practical nurse functioning under the supervision of a registered nurse. And a Nurse 3 is essentially a graduate nurse or somebody who's finished nursing school and waiting to be licensed in the state. And so we used, again, the MEMS licensing apparatus to collect applications. We got each of the schools to sign off on every individual applicant to tell us what level they were appropriate for. And in some cases, the nursing students identified the level that they thought they were appropriate for, and the nursing schools basically signed off and said, yep, that's right, or no, that person really is a 3 or 2 or 1, different than what they had applied for. We made these lists of people available to the healthcare system, both hospitals and nursing facilities, the testing centers and vaccination sites over the course of the past year. And in that period of time, we credentialed almost 1,500 clinical nurse externs and 100 respiratory care students. Lots, the vast majority of whom have been active in the healthcare system. And it's really rewarding. Sometimes we get selfies taken by nursing students who are working at these various places, and they are grateful for the opportunity to make a contribution during this response to a healthcare crisis. As far as I know, Maryland is the only state that's done anything of the sort. We look forward to these people transitioning to new licensed roles as their healthcare careers continue. As with other things that are the result of executive orders, when the executive order expires on August 15th, these folks basically have 30 days to transition to some new status. It's been a very exciting thing. The other thing is we know, unrelated to COVID-19 at all, that some callers to 911 don't really need EMS at all, right? They need something else. Some EMS patients could be treated right there. And there are a couple of jurisdictions in the state that are part of the ET3. I always get this wrong, emergency evaluation and evaluation, treatment, triage, and transport. Sorry. And they are exploring ways to treat patients right there without going to a hospital emergency department. Some patients need to be treated someplace, but not necessarily at an emergency department. And what we know is that some proactive effort, i.e. mobile integrated health, might avert the 911 call occurring at all. And we had already done some work in Maryland in this regard. We had already promulgated the alternative destination protocol that helps EMS clinicians identify patients who might be acceptable to go to, for example, an urgent care facility or substance abuse stabilization center of the sort. And there are a few jurisdictions in the state that actively work on these possibilities. That already existed. And early in the pandemic, we issued the viral syndrome pandemic triage protocol. The idea was to help EMS clinicians identify patients in the field who probably didn't need to go to a hospital emergency department and were suitable for referral to continuing self-care at home with some appropriate instructions for what to look out for. And we've done a lot of work looking at the success of the viral syndrome pandemic triage protocol. What we know is that amongst PUI contacts, person under investigation contacts by the EMS system, the single largest disposition is stay at home, not transported. This table graphic shows you the numbers of PUI encounters and what facility they were transported to over a preceding 28-day period. And you can see there that the single largest disposition, again, is stay at home. And so we have done some work to determine what the effects of the pandemic triage protocol were within the system across the state. And what we know is that when the screening was documented on that tool, when the tool was used and it was well documented, 29% of the patients for whom screening was documented were eligible for care at home. Subsequently, 5% of those patients who were referred to home care required admission to the hospital within 24 hours. But were a proportion of them that weren't related to COVID-19 at all. In other words, they ended up getting admitted to the hospital. 1.8% ended up admitted to the hospital for something unrelated to COVID altogether. So 3 out of 100 people who had screening documented subsequently required admission to a hospital. When screening wasn't documented, what we discerned is that 74% of the non-transports would not have qualified for home care if the screening had been documented. And subsequent 10%, or twice as many of those people, required hospital admission. And so what we believe we've learned is that the pandemic triage protocol was effective at identifying some people who could stay at home, and that the tool, actually using the tool to document the appropriateness of that decision, was important and helpful in identifying the correct patients to stay at home versus other ones. Getting back to a little bit of proactive effort could be helpful in helping to avert an EMS call and taking a patient to a crowded emergency department. We started doing things in the field to stay off the need for a 911 call. These photos are from Montgomery County, where early in the pandemic there was a large population of elderly folks who were potentially exposed to somebody who had been diagnosed with COVID-19. And the Montgomery County Fire and Rescue Service went to the facility with the help of the local health department and screened a couple of dozen people for COVID-19. That was the first foray into EMS clinicians being involved in actual test specimen acquisition. And the health department folks were incredibly helpful in making sure that all the right paperwork and specimen management things were all taken care of. But it was the EMS folks who actually acquired the specimen, and in that way saved probably a couple of dozen 911 calls and certainly taking a bunch of people to the hospital. Fortunately, all the patients who were tested in this particular scenario all tested negative. The other way EMS folks have been involved in responding to the pandemic is by helping with vaccinations, which everybody, I'm sure, knows has been a massive undertaking by the state of Maryland. And as a matter of fact, most EMS agencies are in some way engaged with local health departments in vaccination efforts. Oftentimes EMS personnel are vaccinators at mass vaccination sites. They're helping to monitor patients who have been vaccinated in that period of time between vaccination and given the go-ahead to go home or wherever. They've been involved in homebound visits. And even here at MEMS, we gave over 8,000, nearly 9,000 vaccines to over 5,000 people. Our mission was to help with the continuity of state government. And if you need to know more about that, you can visit covidvaccine@mems.org, where we sign people up. We've actually stopped doing that and are now in the role of helping to vaccinate port terminal workers and folks on cargo ships who come into the Port of Baltimore. But we issued requirements for EMTs to become active in vaccinations. More than 800 people completed the didactic training, and more than 400 people have completed the process, including sign-off by their local medical director to become vaccinators. These folks are out there involved as vaccinators in all kinds of different settings and in different formats. EMTs as vaccinators will also go away when the governor's executive order expires. We were, however, in this most recent legislative session, which I'll talk more about in a second, able to secure a role for paramedics as ongoing members of vaccination teams to the public. Prior to that, it lives in statute that paramedics are limited to vaccinating public safety personnel in terms of flu and hepatitis vaccine and giving tuberculin skin tests. Now they're able to give flu vaccines and COVID-19 vaccines to the public as well, and as long as there are certain requirements are met. But the ability of EMTs to vaccinate will go away when the executive order expires, unless we can change the law when we try again to do so next year. It's no secret, paramedics are vaccinators all over the United States in various forms, and we want to make that an ongoing possibility in Maryland, which I think we've done. Let me tell you that one of the big giant roles the EMS system has played over the course of the past year is in providing information. And this really underscores the importance of every eMeds report that's filled out by an EMT or paramedic and helps us keep our finger on the pulse of the healthcare system in general. We thought it was incredibly important from the very beginning to be able to provide the EMS perspective to statewide leaders that were focusing on assessing and creating the response to the pandemic. Much like how many squares do you see in this picture, the answer depends on how you look at it. And we wanted to make sure that people were looking at things through the EMS lens as well. Maryland EMS already shares abundant information every single day. We are fortunate that we have the statewide EMS patient care reporting system, or EMEDS. That information downloads into the Health Information Exchange, or CRISP, so that every EMS patient encounter in the state of Maryland becomes part of that patient's permanent healthcare record. We share information continuously with Essence, the electronic surveillance system for the early notification of community-based epidemics. That is a collaborative effort between MEMS, Maryland Department of Health, and the CDC. And we believe that all this stuff is critically important to maintaining appropriate situational awareness. So I already showed the graphics that are developed every single day. We do this in conjunction with CRISP, but we have many different data partners in the state that review the data that we collect from hospitals every day to validate its accuracy and ensure that the information that we're generating that is consumable by the public, but also all of the different entities in the healthcare system that are responding to the pandemic, making sure that it's correct and as valid as it can possibly be, so that everybody is singing from the same sheet of music. We pay close attention to the number of PUIs contacted by the EMS system. That's why those questions on the EMEDS report are important. You can see in the top left, that is a representative day in the springtime, and the top bottom right is where we are right now. So we're seeing almost 20% of the cases that we were seeing just a short time ago, which is incredibly reassuring. As you can see in the top graphic for this 28-day period, we had seen almost 8,000 PUIs, and in the bottom graphic, just shy of 2,000 PUIs. One of the things that's really interesting is Dr. Levy, the regional EMS medical director for Region 3, with some various collaborators, including information from MEMS, was able to show a correlation between PUIs that are seen in the EMS system and daily hospitalizations And some of that you think was intuitive. Take a patient to the hospital, they get admitted, of course hospitalizations go up, except that the correlation was for 9 days later. In other words, what the EMS system is seeing on Wednesday translates into what hospitals will experience Friday, 9 days later. And that is incredibly valuable information. And so with the governor's team, I have been sharing this information weekly now for months and months as a clue to what is going to happen with the pandemic information next. So clearly how I translate this information is that the EMS system clearly is a tip of the spear, so to speak, sees the healthcare needs of the community 9 days ahead of time in terms of what the hospital is going to experience. And so if you want to know how to do hospital planning, you look to the EMS system and what it's doing now, and you'll know what you got to prepare for 9 days from now. I'm sure that 9-day phenomenon is very specific to COVID-19 and probably very specific to the various communities in which COVID-19 has been a problem. But it's incredibly important and shows the value of information that's collected by the EMS system on a daily basis. One of the other clues to how the pandemic has been going in the community is the number of cardiac arrests. And cardiac arrests across the state, like much of the United States, changed dramatically with the onset of the pandemic. The gray line are the number of cardiac arrests that occurred in 2020. Don't pay attention to the very end where it suddenly drops off. That's just lacking data for those couple of weeks when the graphic was presented. But you can see the gray line is above the orange and blue lines, 2019 and 2018, without any statistical analysis. You can see that there is a jump. That's not the only disconcerting part, that there were more cardiac arrests. Part of the disconcerting part is the proportion of cardiac arrest transported to the hospital. So presumably developing return of spontaneous circulation or some degree of hope that compels the EMS clinician to go to the hospital dropped by 8% between 2019 and 2020. So there are more cardiac arrests, and a lower proportion of those cardiac arrest people are going to the hospital. That's all very bad news, and undoubtedly relates specifically to COVID-19. Now, in some cases, it probably relates to people who just didn't seek care because they didn't want to for various reasons, afraid of the emergency department or whatever. But in some cases, we believe that cardiac arrest was the first symptom of somebody having COVID-19. And with that, we developed last summer a program to test patients whose cardiac arrest resuscitations were terminated in the field. These were people with circumstances that were felt not to be medical examiner cases. It was intended to alert EMS personnel to possible exposures. These presumably were patients they had a long interaction with, and we wanted them to be able to know that they had potentially been exposed to COVID-19. And these were patients who otherwise wouldn't have been tested. And because they wouldn't have otherwise been tested, they wouldn't have been subject to contact tracing by the health department. And so this facilitated that. Many jurisdictions in the state have been doing this, and you can see over the course of time what the case positive rate has been of the convenience sample we've collected. And I'll point your attention to February, for example, when the case positive rate for COVID-19 patients of TUR patients was in excess of 20%. Even though the test positive rate in the state of Maryland was higher during the wintertime, the test positive rate for these particular groups of patients, patients whose cardiac arrest resuscitations were terminated in the field, was much higher. And these were patients who weren't being tested because they were known to have a diagnosis of COVID-19 and there was some confirmatory thing. These were patients who went to bed with a cold and never woke up. And critically important to understand the dynamics of COVID-19 in the community. And again, we've been using this information to share with healthcare leaders to point out what the trajectory of the virus is in the community and just how devastating, or in case of May, not devastating it has been to people who either defer care or aren't aware that they're as sick as they are. One of the other really interesting things we've done, that we think we're the only state in the country that has done this, is we've used the apparatus of MIEMSS and the EMRC to develop the Critical Care Coordination Center, or the C4. And the C4 was conceived to help stabilize the flow of critical care patients throughout the state between hospitals. So what happened in the spring of 2020 was that hospitals were overrun with intensive care unit type patients and no place to put them. And the patients might be totally appropriate for care at that particular hospital, but they were out of beds. And so were the quaternary care places like the University of Maryland Medical Center or Johns Hopkins Hospital, for example. And so those places were full, and the community hospital didn't have an eye to the availability of other community hospital ICU beds in the state, because typically that isn't the transfer pattern that they make. So they couldn't call 40 hospitals looking for beds, and they had no idea where to try. So we created the C4 to be a clearinghouse for that information. And as of a couple of weeks ago, we had fielded more than 1,000 calls from 58 different requesting hospitals. I'll point out that Maryland doesn't have 58 hospitals. That's a dozen more than we got. We started getting calls from hospitals outside the state who were trying to refer patients into Maryland hospitals because they knew of our success. And we've transferred patients to 59 different receiving hospitals. Again, more hospitals than exist in the state. Patients have gone to Northern Virginia, University of Virginia, Philadelphia, Pittsburgh, and several times to Washington, D.C. And so we've taken advantage of the availability of intensive care beds to meet the needs of Maryland patients wherever that bed happens to be. This is something that we hope to continue as the pandemic wanes, and are looking for funding to keep on doing that. We do this with an EMS person who's the critical care center coordinator, and we do it with an on-call central intensivist physician who may come from any one of the hospitals in Maryland who they get compensated for doing it, but they feel like they're performing a public service and helping patients get to the right care in the right place. And point out that some frequent referring hospitals are also frequent receiving hospitals. So those are the top 10 referring hospitals, hospitals that call us looking for ICU bed availability. But some of those same hospitals are those hospitals. And what that means to me is that hospitals are sending patients that are too sick to be in those specific facilities, but when they have capacity, they're happy to accept patients into their facilities from other places. And this has been part of the real success in that some hospitals that aren't typically critical care referral centers, in other words, not used to receiving patients, have converted their strategy to be able to do just that. And that is an amazing accomplishment and part of the power of a really well-coordinated emergency medical services and emergency care system in the state of Maryland. That's pretty much it for pandemic stuff. In the backdrop are all the usual things that we pay attention to in the EMS system. And I know that we continue to be challenged by our ability to transfer care of EMS patients to emergency department staffs in hospitals throughout the state. The goal is that shouldn't take longer than 30 minutes, 90% of the time. So we have to account for sometimes you'll arrive at the same time as 5 other ambulances, and it might take a little bit longer than typical if your patient's not the sickest one, that kind of a thing. But we are challenged with only 22 of 51 emergency department receiving facilities to meet that 30-minute goal. And the orange line there shows you the 30-minute goal, and you can see for yourself the hospitals that do well and the hospitals that struggle in this regard. And we provide periodic reports to some of the hospitals that struggle the most in hopes that it gives them a sense of their own individual performance, and they can know what sort of challenge they're meeting. It's not new. The top 5 receiving hospitals in terms of EMS patients in the state of Maryland are MedStar Franklin Square, Baltimore Washington Medical Center, Anne Arundel Medical Center, Frederick Health Hospital, and St. Agnes Hospital. And St. Agnes and Bayview basically jockey for that 5th position often. So that's where all the EMS patients in the state are going. Not all, obviously, but those are the most. And you can see how it trails off dramatically in terms of numbers of EMS patients. Can look at the transfer of care problem a number of different ways. One might think, for example, that it relates to the number of EMS patients that come. So hospitals that get more EMS patients are likely to have longer median of transfer times. That's actually not the case. Some of the hospitals that receive the most patients actually are amongst the better ones in terms of transferring care from EMS personnel to emergency department personnel. This one looked at the median transfer time. This graphic looks at the 90th percentile transfer time. Same deal. There's no correlation, significant correlation between the ability to transfer care from EMS to the ED staff based on the number of EMS arrivals. So we want there to be help in terms of helping EMS personnel understand where is the best place for them to go at any given moment. And everybody's familiar with chats. We made a commitment for chats in its current form to transition to something new when we've been slowed down by the pandemic and the availability of really impressive IT folks to help us out. But we're back on track, and there'll be more to follow in the next several months. But we also created a thing called AHA, the At-Hospital Ambulance Dashboard. And using AHA, we can track EMS unit activity at hospitals for the counties there that you see in green. And the counties in red, for the most part, continue to work in integrating or allowing their CAD system to integrate with image trend in a way that we see that we can translate and turn into a dashboard. And this is what the dashboard currently looks like. And if you don't already have this on your smartphone or on your computer, you ought to. And you can go to aha.mems.org/dashboard and see this graphic anytime you want. And this is a recent afternoon, and you can see the EMS system was particularly challenged. But I want to point out, for example, if you look at Good Samaritan Hospital in Baltimore, there are currently 3 ambulances at Good Samaritan when this snapshot was taken. The one that has gotten there the most recently arrived 3 minutes ago, and the one that's been there the longest is 39 minutes. Doesn't tell you that they haven't transferred responsibility of their care. It just says they're still there. They haven't marked back in service from that unit. If you were to click on the 2-unit box or 3-unit box, it would actually show you where those units came from. So if you work in Prince George's County, you might know that there are PG ambulances. You might have access to information that tells you where the PG ambulances are, but you might not know where the ambulances are that came from another jurisdiction. AHA lets you see those. I continue to use Anne Arundel Medical Center as an example because at Anne Arundel they receive ambulances often routinely from Anne Arundel County, Annapolis, PG County, Calvert County, Queen Anne's County, and somebody in Anne Arundel County would have no idea that somebody from PG was at Anne Arundel Medical Center. And it's not that it's a problem that somebody from PG is there, but if it meant that Anne Arundel had 5 ambulances and you only knew of one of the other ones, it might tell you if you had a choice to go someplace else to make that choice or have that discussion with the patient, or at least understand what situation that you're getting ready to arrive to. And so we really hope that everybody will make use of the AHA ambulance dashboard. It's one more piece of information in addition to what is currently chats to help out. And the chats things show up there, as you can see. This is what it looks like on your smartphone. This is a screenshot from my cell phone, and you can filter these things out so it shows you the hospitals that you're typically interested in. In other words, you don't need to see the whole state if the whole state's not relevant to you, but you can see the ones that you want to see just by selecting some filters. We continue to work on an emergency department advisory system that's based on ED patient census instead of being subjective as CHATS currently is, and make it so that an EMS personnel's experience is the same walking into any hospital that's on a particular alert status. Unlike CHATS right now, where yellow means one place and something different a different place, and doesn't really help you very much in making a decision about where to go. Like I said, we've been a little held up by the pandemic, but are getting back on track. Another fact of life that didn't change with the pandemic and is background is the use of naloxone and the opioid epidemic, which continues. It is not a problem that's gone away. If anything, it's gotten worse over the course of the past year for a multitude of reasons. And there's multiple efforts to investigate what those reasons are, some of which I'm sure you can speculate. Even comparing 2020 to 2021, you can see that we continue to use more naloxone in the field than we did previously. And it isn't because we're having more liberal use of naloxone, it's because we're encountering patients for whom use of naloxone is appropriate. Here you can see in Maryland the number of opioid-related fatalities and how it has grown over the past couple of years. In 2020, there was a marked increase in opioid-related fatalities compared to 2019, and it was the most ever since we've been keeping track of this. In terms of the medications that we're encountering, fentanyl is unfortunately gaining preponderance of opioid-related fatalities. Heroin not so much, and prescription opioids, while they make up substantial portion is really much less, significantly less, as you can see, than fentanyl. I'll talk quickly about some of the legislative happenings over the most recent legislative session. And I know this is covered in other forums, but just to give you a sort of EMS take on some of these things. Senate Bill 67 is about vaccinations by paramedics. Unlike the previously existing law, it now includes paramedics who work for commercial ambulance services. It includes the ability of paramedics to provide vaccinations under appropriate supervision and with the right construct of COVID-19 and influence it to the public, which is previously not allowed until January 2023. And then MEMS, in the meantime, has to issue a report about vaccinations to the legislator in 2021, and hopefully by 2023 we'll have a new solution. There was a bill that was going to limit the ability of paramedics to provide ketamine as a in the field administered medication. There was, I'll describe it as objective and qualified testimony by a committee to try to dissuade them, and the subsequent negotiation changed that from a limitation of the ability to give ketamine to an annual report which has to be given to the legislator to monitor how that is going in the state of Maryland. And we are all for that and monitor that carefully as it is. Ketamine continues to be a topic of concern across the country, and there are other states that are doing various things that limit the use of ketamine in the field by paramedics. And I view that as, in large part, as a misunderstanding about the nature of the problem. The problem isn't the medication. The problem is in the way it is being used and the commitment of EMS personnel to appropriately monitor patients who have been given a really powerful medication. And it's in that monitoring and response to the situation as it evolves that we have strength, and continue to emphasize the importance of that. The Maryland Department of Emergency Management was created from MEMA. It transfers responsibility of the 911 board from the Department of Public Safety and Corrections to the new Department of Emergency Management. The 911 emergency telephone system expanded the board from 17 to 24 and created new hiring and onboarding standards for emergency medical dispatch type people, and established requirements for study of the next generation 911 system. There were several no-goes or things that didn't go anywhere, including emergency services exposure to contagious diseases. That was something that MEMS promoted. It passed in the Senate, but no action was taken in the House. Really would have continued to make sure that hospitals provided EMS jurisdictions with information about EMS patients that were subsequently diagnosed with COVID-19. We attempted to increase Medicaid reimbursement for emergency service transporters. There were two bills that would have done that. One would have increased the fee to $300 over the course of 8 years. It's currently $100, and it's flat. Doesn't matter whether you go 5 miles or 50 miles, or you transport someone with a sprained ankle or a cardiac arrest. It's $100. That didn't happen. And the other one would have paid for non-transport of patients and transport to non-EDs. Right now, the EMS system only gets reimbursed if patients go to a hospital emergency department, and neither of those two bills made any action. There was the perennial motorcycle helmet exception bill, which didn't go anywhere. There was one about creating hate crimes against first responders, didn't happen, and another one that would have characterized 911 specialists as first responders. Again, those bills didn't go anywhere. And in other big-time news that is relevant to everybody that participates in the EMS system, we have collaborated with the Maryland Department of Health over the past year to create a supplemental payment program for Medicaid beneficiaries. Again, EMS providers are reimbursed $100 for taking care of a Medicaid beneficiary when the beneficiary is taken to the hospital. What we know is the cost to provide services to a Medicaid beneficiary far and exceed the $100 that Medicaid actually provides. The federal government is willing, and Medicaid is a 50-50 proposition between the state and the federal government, Centers for Medicare and Medicaid Services. And so the state's on the hook for 50% of whatever Medicaid reimburses, and the federal government the other 50%. Well, the federal government is willing to give their 50% of the share of the difference between what is currently reimbursed and what an EMS agency can document as its expenses in providing care to a Medicaid beneficiary. That is the basis of the supplemental payment program. And there are two important qualifications. One is that it has to be a jurisdictional EMS operational program that seeks the supplemental payment, and the expenses that are calculated have to be certified public expenses, which means it has to be the authority that's seeking reimbursement has to be the taxing authority for the jurisdiction, and it has to be tax dollars that are spent. And so what we know is that some jurisdictions will be able to qualify in the current fiscal year for doing this, and some are going to have to continue to do some realignment of billing practices over the course of the next year to qualify for subsequent years. This isn't a one bite out of the apple proposition. This is something that will go on for a couple of years. All the jurisdictions have been briefed on what the qualifications to participate are and given some inkling of what they need to make different in order to qualify for subsequent years if they don't qualify for this current year. But the idea is to infuse the EMS system with what is really a substantial amount of money in efforts to improve the funding for EMS and support innovation. Also in this past year, despite pandemic, we released Vision 2030, the plan for the EMS system for the current decade. It's broken up into these categories of efforts. And if you don't already have a copy, you can download it from the internet. You can certainly send us a request and we'll provide you a hard copy, but it's something that every EMS clinician ought to have familiarity with. It's an easy read. Hopefully it's inspiring. The thing only has life if people look in it and find the piece that speaks to them and find the mantle that they can carry for a short period of time to make the reality of Vision 2030 come true. And with that, I'll stop. It was really a pleasure to have this opportunity to talk to you. I hope that wasn't too much information. I look forward to next year when we can see each other all in person again. And thanks very much. Have a great conference and have a good year.
California Casualty has been endorsed by the MSFA for 10 years for its auto, home, and renter's insurance. It is our honor and privilege to protect those who protect our communities. Happy 10-year anniversary to the members of MSFA. Thank you for all that you do. For more information about our program, please visit www.calcash.com/MSFA. We look forward to seeing you at various local, county, and state events.